Great. Having unmuted, I feel like I'm ready to go.
Okay, great. Welcome, everyone. Today's OHP Bridge Advisory Committee is going to be chaired by Nora. So I will go ahead and hand it over to her to get us started.
Great. Just reminder, I am Nora Leibowitz, she, her, work for Care Oregon, and hope to not embarrass myself. So I start with a little housekeeping. First, closed captioning should be available to all attendees during today's meeting. If you need to access these, there should be a button at the bottom of the screen that says Show Captions. Click on that link and captions should begin to show up. Questions and comments will be taken from OBAC members only until the public testimony portion at the end of the meeting. If you are an OBAC member and would like to speak, please raise your hand before doing so. The Zoom chat in the feature in today's meeting, it allows meeting attendees to message the host and the co-host, but no other meeting participants. Any questions, thoughts, and comments can be sent via Zoom chat to the meeting host and co-host. If you have a supporting resource link to share with the meeting participants regarding an agenda item that's currently being discussed, share that link with the meeting host or co-host, and it can get shared with the meeting attendees. All materials for today's meeting are available on the OHP Bridge Advisory Committee website. Let us know. I can read it out loud, but I feel like no one's going to understand what that series of letters is. So if you don't have access to, if you don't know where that committee website is. Lastly, we ask that all OBAC members remain on camera throughout the meeting, if at all possible. In order to preserve bandwidth, we ask that non-members remain off camera unless they are providing public testimony at the end of the meeting. Roll call.
Yeah, so I will go ahead and call it roll for all of our members. If when I call your name, if you could please come off mute and say that you are present, because I currently have all of the attendees on a very small screen, so I can't see you all. Debbie.
Present.
Great. Mike.
Present.
Great. Jonathan.
Present.
Jonathan, are you present?
Can you hear me?
Oh, there we go. Hi, now I can.
Okay, sorry.
Great. Angelica?
Present.
Perfect. Renisha?
Present.
Great. Nora is here. Michelle?
Present.
Askina?
Present.
Fantastic. Nathan? Nathan Smith, are you present? Okay. Brandon?
Present.
Fantastic. And Kelly?
Here.
Fantastic. Okay, back to you, Nora.
Great. Our first order of business is to vote on the draft October and November OBAC minutes. As a reminder, October meeting minutes were not approved last month due to late distribution. So today we're going to vote on approving minutes from the last two meetings. Both draft meeting minutes were included in the meeting packet that went out last week. Is there a motion to approve the draft October and November OBAC minutes?
I move to approve both previous meetings minutes.
Thank you. Is there a second? Great. All in favor can verbally or hand raise.
Yeah, I can go. I can go through. Debbie, you said
aye.
Mike.
Aye.
Jonathan.
Aye.
Angelica.
Aye.
Renisha. Renisha, do you vote in favor of approving the minutes? If you're speaking, I can't hear you. Renisha, can you hear me?
I think we might have lost Renisha.
Okay,
I don't see them.
we will keep going down the list then. Nora,
Approved, yes.
Michelle,
Approved.
Eskina,
Approved.
Brandon, Brandon, can you hear me?
Aye.
Great, thanks. And Kelly,
Approved.
right. I do believe we have quorum on that. So I think we can move forward with approving the minutes.
Thank you. So we can move on to agenda review. Today's meeting includes a final review of the OBAC rules and operating procedures, presentation on the OHP bridge funding, public comment, and some reminders for the next meeting and close.
Okay.
All right. So this item is the OBAC rules and operating procedures. The OHA staff recorded the suggestions and feedback that folks provided at the last meeting, and they have integrated them into the OHP, excuse me, into the OHP bridge rules and operating procedures document that was sent out to OBAC members last week. Hopefully you all had a chance to review the updated document with the edits that were indicated in red line text. Katie Waldo, OBAC lead staff, will now walk us through the proposed edits and any associated discussion with that. As a reminder, if OBAC members are comfortable with the edits presented, then we'll move on to voting to approve the rules and operating procedures today. So now is the time for seeing them and discussing.
Great. Thank you so much, Nora. So as Nora mentioned, today we're going to revisit our rules and operating procedures. For those of you who may be joining the call for the first time today, just as a quick review, this document is available on the OBAC website, which I'll drop in the chat following this presentation so you can access it. But this is the document that's meant to guide the members, staff, and other participants in the committee on how the committee is run, including the roles and responsibility of everybody involved. So over the past couple of months, we've been going through this document, fielding some feedback from the members, especially on things such as the values and principles, and making sure that it feels like a document that they have buy-in and agency in making. So today we're hoping that this will be our final review of the edits and proposed values and principles. And as Nora said, hopefully we'll get to vote and approve this document today. So as a really quick overview of the changes that have been made, as I mentioned, last month, we chatted through especially the values and principles that are found in this document. And so we've added those that were recommended. We got some really great suggestions from our members last month. And so we've added them in with some explanations for what each one is. We've also added a list of the values and principles that are found in the OHA and ODHS strategic plan documents. So these were originally just referenced in the rules and operating procedures. And we thought it would be helpful to actually write them out so that people can see them easily. Lastly, we had some proposed edits regarding minority opinions. So this is, for instance, if we had a vote and it was 8-3, that group of three, kind of some guidance on what we're expecting from those folks, as well as clarified some guidance around timelines and setting expectations related to member information requests. So we'll go over each of these and starting with our values and principles. So as I mentioned, we had several really great suggestions from our members last month, and we'll kind of go over each one that we've added in with a little bit of an explanation. So the first was we had a recommendation to add value-based care. So this is recognizing that while we are always going to strive to give the best care possible, we also recognize that we are often working in a resource-restricted environment. So really aiming to give the best possible care within the available resources. And this could include, something that we really take into mind when we're looking at things like adjusting the benefit package potentially in the future. We also had someone recommend collaboration. So again, focusing on making sure that we are working together to produce solutions, that we stay solution focused, and that we're hearing the different opinions and ideas across the board and really trying to find collaboration and compromise that works for everyone. We also had someone recommend sustainability. So this is again thinking about when the committee is promoting solutions, recommendations to leadership, that they're considering how those proposed recommendations might impact the sustainability of the program. It doesn't help to, for instance, expand the benefit package significantly if that leads to OHP Bridge no longer being financially sustainable. So thinking about how the recommendations and ideas that we have will impact the program long term with the aim of making sure that this stays available to folks. We also had a recommendation for accountability. So considering how accountability both in the way that the committee operates and in their recommendations. So again, thinking about this from a recommendation standpoint, making sure that we are establishing achievable mechanisms of accountability within the policies that we're putting forward. So we need to make sure that the agency is actually able to follow through on the guidelines and accountability measures that we're making. We also had cultural sensitivity, which again, we want to be thinking both in the concept of how are we operating during our community meetings, the language that we're using, the kinds of conversations that we're having, as well as the way that the proposed recommendations and policies and messaging might impact various communities, and ensuring that we're considering those impacts when we make those recommendations. We also had someone recommend efficiency, which again, all of these are going to be kind of taking place both in the way that the committee is holding conversations, as well as the way that we're considering the way their recommendations will use available resources. So making sure that we're doing the most that we can to use our available resources the best possible way and prevent the most waste. And this includes waste in both funding and time. We also had a recommendation for evidence-based practices being a value and principle. So making sure that as we're making recommendations as a committee, that everybody is considering all of the evidence that is being proposed and put forward by the various SMEs and folks that we have come to present and give you information and perspectives. So making sure that we're really taking those into account before we put forward a formal recommendation. We also had a recommendation for active listening. So again, this plays really well into our collaboration value and principle, making sure that everybody is listening to understand, not just to respond, and really considering all of the different perspectives that are put forward. And this is to each other, to the public, and to the agency staff. Lastly, we had 4 values and principles that were put forward at our last meeting that we felt really played well into each other, but that could kind of be wrapped into one. So this is definitely something I want everyone to kind of think through and see if this feels right to y'all. We felt that a lot of the way that these were put forward kind of felt like maybe they referenced more in practice. So for instance, in clinic actions, and we wanted to try to maybe combine them and refocus them a little bit on committee work. And so we felt that these could all be combined into person-centered care. So making sure that we're focused on solutions and recommendations that are supporting both our providers and our CCOs in providing person-centered care that is considering the needs, values, and preferences of individual members. And this includes making sure that we're advocating for the unique needs of our bridge population, demonstrating fidelity, and ensuring their safety. So this is kind of our re-envisioning of these 4 into what we think is a cohesive single value that captures all of those proposed values. So before I move on to the next 2 kind of more red line edits, I wanted to pause here and see if our members have any thoughts or concerns or questions about the way the values and principles that you all proposed are being interpreted. I also know I talk really fast sometimes, so if you need me to go back and revisit one, I'm more than happy to do that.
I really loved it.
Great, that's exciting to hear. Thank you, Eskina. Okay, well, I'm not hearing any other or seeing any hands. I will admit I can't see all the hands. So if
Can I ask a question?
unfortunately, no, Irma, so right now, as we mentioned at the top of the meeting, we are only taking questions and feedback from our OBAC members. There will be a section at the end of the meeting for public testimony, and we'll cover that when we get to it. Okay, well, thank you, everyone. We'll go ahead and go on to the red lines. If a question pops up from our members regarding the values and principles or a thought, feel free to raise your hand and I will pause and respond to that. Okay, so the next edit that we had was regarding section 2A around the language for member information requests. So our OBAC members can reach out to staff and request further information if they think it would help them in supporting or developing a recommendation, for instance. And we had some edits last month just outlining that it might be helpful to provide further clarification about what we mean by a reasonable amount of time, as well as setting some realistic expectations for how staff respond to information requests. So the first red line that you see here is basically clarifying that a reasonable amount of time will depend a bit on the recommendation. So for instance, if you reach out and you're just needing further clarification on a definition that was used, or a definition for a term that was used in a prior meeting, that's obviously something we can probably respond to really quickly. If you're looking for a lot of data or a more in-depth understanding of a topic and a broader range of information, that obviously might take longer. Additionally, there are going to be requests that we just can't fill. So for instance, if you're requesting a type of document that might include OHP Bridge member personal information, obviously for privacy reasons and the protection of our members, we can't provide that. So just setting some expectations of what we can and cannot do, and recognizing that the level of request and the level of work that it will require will impact what a reasonable amount of time is. That being said, we tried to clarify in the second set of red lines here that we will try to get back to you within, or we'll aim to get back to you within 2 days, 2 business days. So if you request on, 5:30 on Thursday, we'll aim to get back to you by the end of the day on Monday or first thing in the morning on Tuesday. And we will include in that information, in that response, whether or not the request can be filled. If it can't be filled, we'll include an explanation for why it can't. And we'll also let you know what any next steps in the timeline for getting you the information that we can get to you will look like. So just clarifying what that process is going to look like and trying to set some reasonable expectations. The next edit was in 2C, and this is regarding minority opinion. So again, in this case, a minority opinion means the opinion that has the fewer votes, basically. So again, if we were voting on a recommendation and there were 8 in favor and 3 opposed, it would be this is outlining the responsibility of the 3. And so the original language just wasn't super clear as to what we were expecting. And so we wanted to clarify in this language that we are hoping that folks that are coming in with a dissenting opinion, especially, or who are in that smaller group, are aiming to still continue to push the conversation forward. So trying to come into the conversation solution focused and with the aim of continuing to share ideas and work towards common ground. And I think this really reflects back into those values that were suggested last month, especially around collaboration and active listening. So it's just to basically clarify those and kind of work off of the values and principles that were suggested last month. So this was the final edit. Do we have any questions or concerns or edits from our OBAC members here? Don't think I'm seeing any hands. Okay, I think I can hand it back to you, Nora, for a vote to approve.
Great. Do I hear a motion to approve the edits that Katie just went through?
This is Michelle. I so move.
And a second.
Second.
And Katie, is that broad enough, or do I need to also
I would say to approve the document.
to approve the document? Great. Michelle, are you willing to amend your
I amend my motion. Yes.
great. And a second?
Second.
Thank you.
Okay, I will run through the names again. So Debbie,
Yes.
yeah, great. Mike,
Aye.
Jonathan,
Aye.
Angelica,
Aye.
Renisha,
Aye.
Nora,
Aye.
Michelle,
Aye.
Askina,
Aye.
Nathan, if you happen to be here now. Okay, Brandon.
Aye.
And Kelly.
Aye.
Fantastic. Okay. We have approved the rules and operating procedures. So I will post the approved version on the website following this meeting. Thank you, everyone. And I will hand it back to you, Nora.
That was very efficient.
It was. We're way ahead.
We are way ahead. You all have earned yourselves a 10-minute break ahead of schedule. So you can use it to celebrate. And we're going to pause the recording and we will see everyone back here. It is now 10:26, so we'll see everyone back here at 10:36.
Great.
Thank you,
everyone.
Nora.
I also just dropped in the chat the link to the OHP Bridge Advisory Committee or OBAC website. And this includes information on the OBAC itself, as well as the meeting information and materials that I mentioned at the beginning of today's discussion. We'll also be posting the early winter meetings, so our January, February, and March meetings this week or early next week. So keep an eye on that website for those dates and times. Nora, are you there? Go ahead and hand it back over to you.
Yes, I am. Sorry, I just realized I was not on camera.
No worries.
Fantastic. So we now are going to hear from Tim Sweeney, OHP Bridge Policy Lead, who's joining us to provide an overview of OHP Bridge funding. As a reminder, we're going to focus on informational sessions for the first 6 months of OBAC meetings. The goal of these presentations is to ensure that everyone on the committee has a common foundation to work from once we begin making recommendations to agency leadership. Today's presentation is the first segment of a presentation series that will focus on OHP Bridge funding. This portion will focus on the various funding streams and components for OHP Bridge. Next month, we'll explore capitation rates and rate setting more generally. As a quick reminder, we are only taking questions from OBAC members at this time. There is time reserved at the end of the committee meeting for public testimony. And for OBAC members, please remember to use the hand raise function so that we can see you when you have a question. And given that there is nothing more exciting than healthcare funding, I am sure you will all have lots of questions. So take it away, Tim.
Great. Thank you, Nora, and good morning, everyone. As Nora said, I'm Tim Sweeney. I'm a senior health policy analyst with OHA and have been involved in the policy development work related to OHP Bridge really back since the legislature considered a bill and created a task force and helped staff the task force. And we'll talk a little bit more about that as part of this presentation. So I've been working on this program for coming up on 3 years now. So today I'm going to walk through a bit more program background and provide some more detail related to how OHP Bridge was established, how it's funded, and how our federal approvals and funding authority inform the state's operation of OHP Bridge. I know that familiarity with this background and really funding details of OHP generally and OHP Bridge varies extensively across the committee. So really, please don't hesitate, committee members, to ask questions as we go. I definitely don't need to hold them all for the end, especially if they're really related to what's on the screen or if there's some background that it feels like you don't know. Please don't hesitate to raise your hand and I'll try to watch, but also if I move on before seeing a question, somebody let me know. So we're going to start with some of the basic details and distinctions for OHP Bridge Basic Health Program and OHP Bridge Basic Medicaid. And so as a reminder, OHP Bridge consists of these two programs. Bridge Basic Health Program is managed exclusively by CCOs. There's no open card option, and that is really due to the federal structure of a basic health program. And as of the beginning of early last week, OHP Bridge Basic Health Program covers about 30,600 members. The second program, OHP Bridge Basic Medicaid, does have an open card option in addition to CCO coverage. And this was created to ensure that American Indian Alaska Native individuals who, when they are eligible for Medicaid, have a federal right to opt out of mandatory managed care enrollment. We wanted to, and frankly, this is a state right as well. And we wanted to duplicate this structure in OHP Bridge, and the way that we were able to do that was through the creation of OHP Bridge Basic Medicaid. And right now, this program covers about almost 830 people as of early last week. So a little bit more detail about these two programs and really the federal authority under which we operate them. So Bridge Basic Health Program is a basic health program which was created in Section 1331 of the Affordable Care Act. We put together a blueprint. The state puts together a blueprint which articulates how the program is going to be structured and a variety of details about the program. And CMS approved that blueprint in June of 2024, enabling Oregon to launch OHP Bridge Basic Health Program on July 1st. Approval remains in effect until either the state seeks to withdraw the program or unless the federal government identifies that the state is not operating the program in accordance with approvals or how other requirements of the program and the federal government could identify some sort of non-compliance that would lead to the program going away. But it, unlike the waiver that I'll discuss in a second, as long as both parties want the program to continue, it operates under that blueprint indefinitely. OHP Bridge Basic Medicaid is authorized through a waiver amendment through part of Oregon's broad 1115 Medicaid waiver. This amendment was approved also in June of 2024, enabling us to launch both programs simultaneously July 1st. Unlike the BHP blueprint, which remains in effect, this waiver must be renegotiated or reapproved every 5 years. And so the current waiver the state operates under goes through, I believe, September 2027. So this program is established in that 1115 waiver until then, and then it would be renewed with other parts of the waiver. Okay, so the next slide then, a little bit of a high level on the funding sources, and really the separate funding of these two programs is because they're separately approved at the federal level. So OHP Bridge Basic Health Program receives funding into a trust fund, and there is a per member funding allotment from CMS to the state of Oregon based on enrollment in the program. This is a defined formula in a federally defined formula based on what would come to enrollees had they been on the marketplace and getting marketplace tax credits. So the funding structure is set in federal law and rule with additional detail in what's called the annual payment notice that comes out every year. And I'll go into more depth on this funding formula in a minute. OHP Bridge Basic Medicaid is then funded just like other Medicaid programs in the state. Federal funds cover a portion of the overall expenses, and state funds cover the rest. Right now, the federal share for this program is about 60%, with the state paying about 40%. This funding structure is more open-ended than for basic health program. It is literally a match rate per dollar that's spent. So if we spend an extra dollar, the state kicks in 40 cents and the federal government 60 cents, and there's not a set allotment in the same way that there is for basic health program. Okay, so that's at a very high level, and now I'm going to go through the basic health program federal funding formula in a little more detail. I think for short, I will probably refer to this as the BHP funding formula, and just as a reminder, this is the structure only for OHP Bridge Basic Health Program, and we'll talk about the Medicaid piece at the end of this as well. So as I just mentioned, at a high level, the funding formula is structured to calculate the amount of federal tax credits that would have come to Bridge enrollees had they instead been receiving tax credits to buy private coverage on the health insurance marketplace. The whole broad structure of this program in the ACA is that it is an alternative to marketplace coverage for this defined population of adults with income between 138 and 200% of the poverty level, and that states sort of like take the risk to cover this this population, and then states get funding based on what would have otherwise gone to these individuals in the form of these tax credits. And so at a high level, the funding formula is here on the screen. PTC stands for Premium Tax Credit. So this is what folks would have gotten in the form of federal tax credits to buy a qualified health plan, a QHP, on the health insurance marketplace or healthcare.gov. Then there are some adjustment factors that sort of try to take into account a handful of things that would be potentially part of rates if a state didn't have a basic health program, or if a state didn't have a reinsurance waiver, which Oregon has, and a few other sort of adjustments that are made in the payment notice in the federal rules. And then all of that is multiplied by 95%. Basically, the trade-off for the federal government is you get all this money that would have gone to people to buy health insurance on the marketplace, but you only get 95% of that. So in theory, there's some potential savings for the federal government as well. And so then on the next slides, we'll go into each of these sort of formula components in a little bit more depth. So premium tax credits that would be paid to folks had they been on the marketplace are based on actual premiums, the actual premiums people face. It's based on the cost of the second lowest silver plan available to a person, which is based on their age and where they live. And then the amount of tax credits they receive is sort of based on a federal formula that is dependent on somebody's income. Somebody at a lower income level would receive a higher federal tax credit than somebody at a higher income level. And so all of that is part of the calculation of what would the tax credits be that would be available to folks had they instead been enrolled in a marketplace plan. So again, the variables that affect this at a sort of the individual level, at the enrollee level, are a person's age, their income, what part of the state they live in, and their household size. So all of that sort of informs a calculation that happens at the federal level of what would the tax credits be. So the next slide are adjustment factors. So there's 3 primary adjustment factors here. One of them is called the population health factor. This accounts for, or this could account for the fact that if you take a population out of a market, that could affect the premiums of the rest of the market, right? If we think, for instance, that the population of folks who would leave the marketplace and come to a basic health program are higher cost for whatever reason it could be, right? That they're higher cost, and when that population leaves, premiums for everybody else drop. That dynamic could lead to lower premium tax credits than otherwise would have been if this cohort had stayed in the marketplace. So if a state thinks that's happening, the state can gather a bunch of data to sort of like figure this out and seek a population health factor adjustment. It could be a positive adjustment if that population really is higher cost than the marketplace folks as a whole, or it could be a downward adjustment if this population is actually lower cost than the folks who remain on the marketplace. Then that would lead to a reduction in the state payment rate. So that population health factor is a state option. So far, neither of the 2 other states that have operated a basic health program have taken the federal government up on that option. In large part, there's a great deal of uncertainty, and I think it would be a lot of work to identify this difference for probably a pretty minor change in the overall funding formula. So the next one is, I'm going to go through the next 2 items in this blue box. There's also what's called a premium adjustment factor. This is similarly complicated, but there is a practice called silver loading that states operate when they don't have a basic health program, that when a state creates a basic health program, that practice will eventually go away. And so there's an adjustment to the funding formula that sort of says, we know if you didn't have this basic health program, you'd be doing this other thing that increases rates. So we're going to increase the rate in the formula here to account for that. And then finally, there's a reinsurance estimate, is that several states operate programs through their, in Oregon, it's through our insurance department, through the Division of Financial Regulation, that reduces premiums by creating what's called a reinsurance pool. And so there's an adjustment here that accounts for that, basically, that says your premiums in your state are lower than they would have been, thus premium tax credits are lower than they would have been without this reinsurance program. So there's a formula adjustment to add that funding back in. So all of these adjustments are kind of like trying to get back to an apples to apples comparison of what the individual market, what premium tax credits would look like in Oregon, if not for the existence of a basic health program or a reinsurance waiver. It's kind of like getting the formula correct. Sorry, now we can go to the next slide. There's another, oh, do I hear somebody?
That was me. I was just apologizing.
Okay, no worries. There's another adjustment factor. It's called the income reconciliation factor. That is, again, it's an adjustment above or below 1. So this 0.95 means it's sort of like almost a 5% hit to what the formula is spitting out. If it was 1.05, it would be that 5% bump. But what this accounts for is the difference in marketplace covered members of their advanced premium tax credit, what they think they're going to qualify for, and what they actually qualify for in tax credits. Or another way to think of it is sort of like an adjustment that takes into account that the expected income that a person might report at the beginning of the year doesn't necessarily exactly tie to the actual income that they get. And if what this number below 1 basically means is that on average in the marketplace, people expect to make less money than they end up making in the year. So they expect to have a higher premium tax credit than they end up getting. And so this is just an adjustment to account for that fact that we get somebody's expected income and process their application and get federal funding based on their projected income, but in reality, they often end up with more income than they initially project. And this is a number that changes every year. It's 0.9520 in 2025. A couple of years ago, it was actually above 1. And so there's some uncertainty about that year to year. And then again, at the end, and I think we mentioned this at the beginning, all of that calculation is then multiplied by 95% to get the ultimate amount that is paid to the state. And then really all of these calculations essentially happen at an individual level based on actual enrollment in the program. So that was a lot. Maybe I'll just pause here for a second to make sure if anybody wants to sort of like go over any of that again, or if there's anything I said that felt especially confusing. I know it's a lot of detail. And as questions come up at the end, we can certainly circle back to everything. So moving right along then, the Medicaid financing piece is, oh wait, sorry, one more detail about this. So, no, sorry, the next slide is right. I was just forgetting what the next slide was. So BHP funding is based on federal tax credits for the marketplace. In 2021, I'm sorry, this one says 2020, but it was it was in 2021 that Congress and the Biden administration added enhanced premium tax credits for marketplace enrollees. And this was part of the federal response to the COVID pandemic. So the increased tax credits were available to everybody on the marketplace. And the effect of these increased tax credits, these enhanced subsidies, is that it boosts state revenue for basic health program because that revenue is based on marketplace tax credits. these enhanced subsidies are slated to expire at the end of next year, at the end of 2025. It is worth noting there's a great deal of uncertainty as to whether they will get extended or not. But it's also worth noting that these enhanced tax credits were initially part of the American Recovery Plan Act, but then later added or later extended in the Inflation Reduction Act for an additional 3 years. So they were initially put in for, I believe, 21 and 22, and then they were extended for 2023, 24, and 25. So it's not just the initial time period. It has been extended once, and so hopefully that bodes not horribly for the potential that they can get extended again, but really there is a great deal of uncertainty. And it is worth noting that the funding bump that we get for BHP is significant, and not having that funding bump beyond 2025 would have a material impact on the amount of money the state gets, and could have an effect on how the state operates this program. I see a hand up. Go for it, Mike.
Yeah, thanks, Tim. When you say significant, like approximately what percentage of the overall funding is based on these enhanced federal tax credits?
I would say it is plus or minus. It's about a 15% bump, plus or minus. And it really will depend on the actual income level of members. If they're closer to the bottom end of the BHP range versus the top end, there could be a difference there. But we are working with some actuarial consultant partners to get a more I don't want to say concrete, but a more detailed estimate of what that funding impact is. What would be the impact of these enhanced subsidies going away? Because it's not just as simple as, oh, the funding amount is a 15% bump, right? If it changes enrollment patterns in the marketplace, that can also affect premiums. And so there's maybe sort of like a couple of iterations that would then affect what funding level the state would get. So that could make that more like a 10% instead of 15, or maybe make it something higher than 15.
Okay. All right. Thanks, Tim.
And I guess I'll say, for further context, that 15% is taken from some very early analysis that was done for the task force by our actuarial partners to like set some initial revenue estimates for what the state might get for a BHP, and they did some with and without the ARPA extension, and that's about what that impact was. So again, it's a couple years old, but it was based on some analysis. Anything else before moving on to the Medicaid side? Okay. Medicaid funding is much, see, I gotta always look ahead what's next. So actually one more bit, and really the flow of federal funds for the BHP and into the trust fund is a little different. So what happens is the state provides data to the federal government on what we think enrollment in OHP Bridge Basic Health Program is going to look like for a 3-month period of time. So for initial July, August, September enrollment, we submitted that data to CMS in April and said, here's what we think enrollment in this program is going to look like by county, by age, by income level. And then CMS takes our enrollment projections and basically runs it through their funding formula. And that creates a funding amount that the state gets for that calendar quarter. Those dollars are then sent to the state, and the state must deposit them into our BHP trust fund, which is a fund that states operating a BHP have to create to receive the federal funds. That's in federal rule. And once dollars are in that fund or in that trust fund, they cannot be used for anything else. The state cannot take those dollars and direct them towards roads or Medicaid or anything else. You know, those dollars have to be used in accordance with federal rule, basically, and spent on allowable expenditures for people enrolled in OHP Bridge Basic Health Program. The state then takes those dollars and, similarly to Medicaid, pays monthly capitation rates to the CCOs based on their enrollment, can pay directly to providers for other services that are not part of the CCO service package. For instance, there's a set of mental health drugs called 7-Eleven drugs that are carved out of CCO contracts, that those are still covered services for members. And so, reimbursement when those for those services are paid directly from the trust fund to providers. So that's where the money goes. And then at the end of the quarter, the state has to look at who is actually enrolled in the program and send that information back to CMS. And so if we thought we were going to have 20,000 people covered, and in the end we have 25,000, we'll send that information back to CMS. They'll update the sort of calculation of what should have been paid to the state, and then that will come through on future quarterly payments. So we're kind of always going to be in this posture of providing prospective enrollment estimates to the federal government and providing retrospective actual enrollment, and all of that will be reconciled moving forward, and that will be reflected in the quarterly payments that come from the federal government to the state. I'll pause again before leaving this one, because it really is the Medicaid slide next. Third time's a charm. Is there any further questions, or did I explain that okay? Okay, moving on to the Medicaid piece. So OHP Bridge Basic Medicaid, so shifting gears back to the basic Medicaid program, is funded in a similar way as other Medicaid eligibility categories, or as the rest of the state's Medicaid program. It is jointly funded with state and federal funds. Again, it's all based on a state-specific match rate that is called the Federal Medical Assistance Percentage, or sometimes FMAP. And right now that is about 60% in Oregon. So for every $10 million the state spends on this program, or every $10 million in overall cost, the federal government pays $6 million and the state pays $4 million. And again, I did mention this before, but this program is authorized at the federal level via a provision in the state's larger 1115 waiver. It's worth noting that as part of that waiver amendment, it is explicitly said that basic Medicaid and basic health program, the two components of OHP Bridge, must offer identical covered services to members. The federal government is, and we didn't try to have it any other way, but the federal government is very clear that these are two programs that are delivering the same benefits to members. The one big difference is the establishment of the right to opt out of mandatory managed care enrollment for American Indian Alaska Native members who are covered through basic Medicaid. Okay, so that's sort of how the funding works, and now offer a little bit of more background and kind of level set as to how that informed the development of the program. And so House Bill 4035, which is what created the task force and directed OHA to develop this OHP bridge, envisioned a program with minimal state funding and no member costs if possible. And so for OHP Bridge, that meant developing a program to operate within the confines of the federal funding formula. And for basic Medicaid, the fact that it is a smaller program, there is state funding available for the state match for the program, and it is basically part of the overall, part of Oregon's overall Medicaid budget. And so the result, really, because of all of this, is a program that was very specifically designed and developed to operate within the confines of federal basic health program funds, with state dollars only being used for administrative expenses, state match for basic Medicaid, and for basic health program to cover services for which we cannot use federal funds. There are just always some limitations for that. And so that did then lead to a program design that did not include any member costs, and that pays CCOs in a manner similar to in Medicaid. All that said, the fact that enhanced federal funding might go away after 2025 could create a funding issue for Bridge Basic Health Program, and because the two programs need to provide identical benefits to members, could necessitate reconsideration of the funding structure and plan design of OHP Bridge as a whole. And so now I'm going to walk through a little bit want to highlight some of the plan design and funding structure considerations that were part of the task force's discussions back in 2022 as they were developing their recommendations for structuring the program and for the plan design, while similarly navigating a space of uncertainty surrounding federal funding. So this is a bit of a back in time conversation, but it's also, I think, relevant because federal funding uncertainty will really always kind of be there. So broadly speaking, there are 4 plan design levers that the task force discussed as part of their conversations to ensure that OHP Bridge could operate within available federal funding and in absence of significant state funding. So the 4 things, the different levers that they could have pulled to adjust the program, or that they discussed, were the program could impose costs on members, such as monthly premiums to enroll, or the establishment of co-payments or other cost sharing at the point of service. So that's 2 of the levers. The state could seek to lower the amount paid to CCOs and providers who are serving OHP Bridge members. So that's 1 lever. And the state could consider reducing the scope of benefits covered by OHP Bridge. And in general, in this case, it says there, decrease services below OHP. There were sort of like different starting places with all of this. Less about sort of where we are now, but broadly as as an overall conception, you can lower reimbursement rates to reduce the cost of a program, right? You can reduce benefits to reduce the cost of a program. Now, of course, none of these options were preferred by the task force or by the legislature in how they directed the task force to do its work, nor by the state in developing the program that was ultimately approved by CMS and implemented on July 1. But still, it's useful to sort of further examine how these options were considered and discussed at a high level, especially related to their impact on members, on CCOs, and on providers. And so the next slide offers some of those considerations. In terms of covered services, it was noted that reducing services covered by OHP Bridge or creating a separate set of covered services compared to what CCOs deliver to OHP Plus members could create operational challenges for CCOs. It could cause confusion for members as they move between programs. And on the other hand, the task force realized that it would create some equity concerns to think about covering services in OHP Bridge that were not covered by OHP Plus, that are not covered by Medicaid. It would be potentially problematic to cover additional services for a higher income cohort than the state is covering for folks for adults on Medicaid. For enrollee costs, the task force considered the types of options and the different impact on members and providers that could arise of either adding premiums or cost sharing at the point of services. Certainly, monthly premiums are probably less administratively burdensome to administer, but they may deter enrollment in the first place, so we could see fewer people getting covered. Copays would certainly add administrative burden to providers, to CCOs having to track how much people pay, to the state having to track how much people pay, and also would create barriers to accessing services. And then from a payment rate standpoint, there were concerns and considerations related both to ensuring adequate rates, understanding that if rates are too low, participation by CCOs or providers could suffer, but also there were equity implications of setting payment rates higher for this population, for members enrolled in this program than are paid for folks on Medicaid, and some worry about setting up any kind of tiering that would make a provider or a CCO treat members on OHP Bridge differently than OHP Plus, or be more willing to serve OHP Bridge than OHP Plus. So these were some of the types of concerns that were brought up, the discussions that were had by the task force, certainly in getting to the space where the end recommendations were to cover the same services that are covered, but the same services delivered by CCOs that are covered for OHP Plus. So the two exemptions are long-term services and supports, and the HRSN services that are getting rolled out as part of the waiver. The decision was to not have any enrollee costs, and the decision was to start with payment rates that are comparable to what is paid for Medicaid, to have a rate setting process so that the state is paying CCOs in a similar manner, and thus setting up an expectation, if you will, that providers are then getting paid in a similar manner from the CCOs. Lastly, we wanted to offer this sort of like high level. Oh, I see a hand. Nora, please.
I just wanted to, I guess, looking at this very nice visual about the different kinds of the different levers. My memory is that there was pretty good alignment between like the CCOs and providers and folks, patient or member advocates, that having things be the same as much as possible was really the ultimate goal for everyone, and that using enrollee costs was a really not preferred option. And I think that, you know, the reason that that's not a preferred option is like hits the CCOs and the providers and the members differently, but they all were aligned in the like, oh, we don't like that one.
Yeah, I think that's great context, and I agree that especially enrollee costs were viewed probably at the bottom of the list, if you will. On some level, it's always tough because, you know, like you said, the vision is a program that looks the same, that is delivering the same benefits, that's paying the same, that is the same to operate. And so it always is. Sometimes for me, it comes across as like all of these options are kind of like tied at the bottom. But I do agree that especially the impact on members was a really high concern for the task force. Thanks for bringing that up. So the last thing that we wanted to leave you with was, given all of this, there's something that sort of shows where the programs are flexible, or where the state has flexibility in terms of funding these programs. And it's worth noting that, you know, in large part, these programs are funded through federal funds, and the state has very limited, basically no flexibility in the structure of those federal funding formulas. The structure of Medicaid funding and the match that is set at the federal level every year, and that there is uncertainty in both cases, both for Medicaid and for programs operating under the Affordable Care Act, as to what might happen from a federal financing standpoint over the next couple of years. But it is worth noting that it's largely an area where the state doesn't have flexibility. The state, the legislature specifically, does have flexibility as it relates to whether to add general fund dollars, and certainly, you know, the committee could recommend that the agency request general fund, but it's also worth noting that it's still at the end of the day, a legislative decision under their appropriations authority. And then similarly, when we get to other potential financing components, and you know, member cost as an example, because it would bring in funding. Neither program has member costs, and as Nora just said, that was not high on the list of the task force. But it is an area where there is flexibility that the state could impose if it chose to. And again, sort of playing out the theoretical impact, it would be the committee could recommend implementing or considering or seeking member costs in order to deal with funding shortfalls in the future. It is worth noting, like in a lot of ways, state flexibility is always somewhat limited by federal rules, and there are federal rules around premiums and copays for basic health programs to ensure that there are member protections at a federal level in terms of what states can do. That is the end of this funding presentation. Happy to sort of sit here for a second and make sure that nobody has any additional follow-up questions. Certainly, if there's feedback y'all have of like things that it felt like we could cover more as we build the slide decks and agendas and presentations for the upcoming meetings, definitely pass that information along so we know what else to add. there are no more questions, I think I will hand it back
Kelly,
to, oh, I see a real hand, yes.
Okay. Hi, I have a question about the premium reimbursement program that you have for just regular OHP coverage. So it was if somebody is paying a premium for their health insurance and there is somebody who qualifies for OHP, then the sorry, the policyholder gets the amount they pay in a premium paid back to them. Is that also going to be the same if the person is on the bridge, or is that just for basic OHP?
So that is a Medicaid specific program, and it calls into one of the broad Medicaid and BHP differences is that somebody on Medicaid can have other health insurance coverage and still be on Medicaid. And so, like you said, this premium assistance programs are set up to sort of like help. Medicaid can basically pay the premiums on behalf of somebody who's got an employer plan or something like that. In the case of OHP Bridge, and this is for both BHP and basic Medicaid, somebody who is eligible for other health insurance, other affordable health insurance coverage that meets a minimum value threshold that's also set by the federal government, would not be eligible for OHP Bridge, BHP, or basic Medicaid. So it's sort of like, because that's a similar rule that's in effect for folks to be eligible for marketplace tax credits, there's not really the ability for us to have a premium assistance program for OHP Bridge. And again, just to reiterate, that is fully a federal level, a federal law and rule restriction. Anybody else?
I don't see anything in the chat. I did want to flag, I've had a couple people reach out during this presentation asking about a more general overview of OHP Bridge. So if this is your first meeting attending on the OBAC, I do want to flag that there is a recording of our October meeting where we provide a more general overview of the program itself, of the benefit package and project. So I've dropped the link to the meetings page in the chat, and you can access both the slide deck and the meeting recording link there as well. So that provides that more general background. Okay, well, I'm not seeing any hand. Oh, Mike.
Thanks, Katie. So I don't know if this is an appropriate question for Tim, because it really doesn't deal with funding, but this conversation had me thinking a little about this. So it seems, and I may be misspeaking on this, and if I am, please correct me, Tim, OHA staff, that people really have the ability to choose between OHP Bridge and kind of what's on the marketplace, for lack of a way to describe it, kind of in a basic terms. I'm kind of curious to know what the differences are between services between what OHP or BHP and basic, whatever the two are, and then what the second lowest rated silver plan that was discussed kind of earlier. Because when I look at the levers, if those are the only levers we have, there's not going to be one that we're going to be happy about. So for me, if I had context related to kind of what we're choosing between versus them being an OHP to begin with, and then going on the marketplace instead and grabbing one of those second rated or the plans that Tim was talking about, it would help me to understand from context. And part of my question comes from being on the Universal Health Plan Governance Board. I'm on one of the committees. And an additional lever that was there that we didn't discuss today was membership. Like, who can actually be on OHP or Universal Health Plan. That did not seem like it was something that the task force either considered or want us to consider. So if that's not an option, I'm kind of wondering how we would compare with what other alternatives might be if they weren't on OHP and they had to go to the marketplace to grab that health insurance.
Yeah, happy to take those, and there's a few sort of questions in there. I'm going to start with one overarching clarification: is that members don't have a choice between marketplace coverage and OHP Bridge. In creating a basic health program, that becomes the option for federal assistance for people who are eligible for that program. In the very short term, medium term, a couple of years, because folks in this income range have been on marketplace plans leading up to the creation of OHP Bridge, there will be people in this income range who do stay on marketplace plans because they can automatically re-enroll from one year to the next. So it's sort of like folks have to take action to move to OHP Bridge. So there's sort of a almost an option at the beginning to not take that action and stay in a marketplace plan. But broadly speaking, somebody newly applying for coverage is identified with income in this range. They are eligible for OHP Bridge and not for marketplace tax credits. That said, the question about sort of like comparing services across marketplace plans and OHP Bridge, I would say that broadly speaking, OHP Bridge has a more robust package of covered services, but it's very comparable. We, as a state, in setting up a basic health program, we have to cover the 10 essential health benefits that are also required for marketplace plans to cover. Frankly, as a Medicaid program, in taking the Affordable Care Act Medicaid expansion option, the service package that is available that is created as part of that also must meet federal rules around the essential health benefits. So we, as part of the blueprint, walk through our list of covered services, and it's a several page section of the blueprint that just delineates for each of the 10 essential health benefits, like the services that are covered. And so broadly speaking, it's very similar to what's available on the marketplace, except that some things that are part of Medicaid are covered by, or that are traditionally Medicaid services that are not traditionally covered by private health plans are covered as part of OHP Bridge. And a couple key examples are non-emergency medical transportation is a covered service in Medicaid. It is part of the OHP Bridge service package and would not be something that is covered by marketplace plans or really any commercial health insurance. Health-related services that are like not quite exactly covered services because a person's not entitled to them, right? But that are payable from CCOs with dollars from their capitation payments. Those are available to OHP Bridge members, and that's not typically something covered by marketplace plans. So those are sort of a couple of the big examples of areas where this service package is covering services that would not be covered in a marketplace plan. I think the broad then big difference is it does come back to member cost, right? If somebody is enrolled in a bronze or silver plan on the marketplace, even with cost sharing reductions available to folks below 200%, there's some level of out-of-pocket costs that are part of their plan, and there are no out-of-pocket costs for OHP Bridge. I think beyond that, then the differences get into provider networks and structure of commercial health insurance plans and how that differs from from a CCO and the way that we've set up Medicaid managed care. And that's certainly something we could talk a little bit more about. But where the detail, the nuance of it all really becomes quite detailed and in the weeds. And I see Laurel's hand up, so I'll pause for a second and feel free to add to all of that, Laurel.
Thank you, Tim. Super appreciate it. And I think I wanted to chime in, Mike, just because I'm also supporting the Universal Health Plan Governance Board. And so I was in that conversation with you as well. And I just wanted to name that the task force did, to some extent, think through who would be eligible for this program when they were thinking through whether or not they wanted to take the route of a basic health program. It was not like a foregone conclusion that they would be pursuing a basic health program. The legislation, House Bill 4035, just said that we would be creating a program, and we talked through the various federal authorities that could create OHP Bridge. And when we chose a basic health program, the federal, the Section 1331 is pretty prescriptive on who is eligible. So I guess I just wanted to offer that, I do think the task force talked about eligibility a little bit. It was in the context of what federal authorities we would be pursuing. And now that we are pursuing a basic health program, we just don't have the flexibility with respect to eligibility that would enable that type of conversation.
Okay. All right. Thanks, Tim and Laura. And part of my lens on this, and I appreciate the clarification, Tim. I wasn't trying to hint that people can choose just if OHP Bridge was not here, what would they be choosing was kind of what I was sort of hinting at to some degree. And what my main crux or kind of my thought on this is I don't want to have us create a plan that's worse than they would have if the plan didn't exist. That's kind of what I'm getting at. And I just want to make sure that we have that context where we're not pulling the lever so much just to make it sustainable when maybe the alternative might have been better.
Totally hear that and super appreciate the additional thoughts. Yeah, Kelly.
I just have a question about people who, one thing that can happen is if you're on a marketplace plan and you have a private, insurance that you've picked through the marketplace, and then you drop down to, the OHP Bridge. If you have a provider that doesn't accept OHP Bridge, is there any sort of mechanism for a member to stay with that provider? I mean, certain services, maybe not as big of a deal, but something like a mental health professional where you've developed a trust and a relationship with, that it's, you don't want to just go find, it's not as easy to just get somebody new. Is there, yeah.
Yeah, I mean, and this is great question. And it certainly concerns that we always hear as it relates to, frankly, any health plan is the provider I want to see part of that health plan, right? And so a couple thoughts. One is that there is a possibility for something called a single case agreement where a provider who's not sort of like part of the CCO's network could have an agreement with the CCO to be able to get paid and provide services to a specific member. The caveats to that are, though, that the provider does have to be, enrolled with OHA as a Medicaid provider, and then could both pursue being in network with the CCO's network or a single case agreement. But that is an area where the structure of Medicaid and the way that OHA oversees this, the provider does have to be part of that system. And if the provider doesn't want to enroll with OHA as a Medicaid provider, then the options are limited to get them connected to a CCO. And it's certainly, you know, Nora, Mike, others on the committee with CCO and provider experience, feel free to add some context as to how that process sort of works in your mind, or how y'all approach it, or any other thoughts.
I think you've described it pretty well. What I would say is part of what Tim is getting at is that the state is trying to make sure that every provider, for lack of a better term, jump through a number of hoops to show that they are who they say they are, that they are qualified to provide services, et cetera. And some providers feel like that burden to have to, you know, put in your credentials and et cetera, is not worth what they're going to get paid. And so they might not want to do it. But I think that it's one of those challenging things where the state can't force providers to participate, and the CCO obviously can't force providers to participate, but we do. I work for Care Oregon, which has some CCOs, and we have a whole team that works with providers to try to say, well, do you want to be part of our network? Do you want to participate as a non-contracted provider, but, you know, just for this case, as Tim has expressed. So we do make an effort, which is obviously not like every case always works out, but yeah.
Thanks, Nora. And a great question, really. Anything else? And I think I mean, I appreciate that not all these questions are exactly about the slide deck, right? That's sort of like the thoughts that come up after thinking about the financing and funding and the implications. So definitely feel free to consider other questions. Obviously, pass them along for us to make sure and bring back next time too.
I'm not seeing anything in the chat. So I think we can hand it back to you, Nora, and I will share screen again. Thank you so much, Tim.
Thank you. So we're going to move on to the public comment portion. The OHP Bridge Advisory Committee welcomes and deeply appreciates public testimony. It's one of the most powerful ways that we demonstrate our commitment to profound listening and learning. Deep listening means we will not respond to what you share, and we will not attempt to fix or resolve the question or concern that you bring today. We also won't interject to correct inaccurate comments that are shared as fact. We will, however, bring it fully into our awareness, understand it as an important consideration for our work, and listen with careful attention, respect, and the honor that you deserve. We want to acknowledge that time held in our meetings to hear public testimony is meant to provide a voice and perspective from that individual and is not a representation of the OHP Bridge Advisory Committee, its members, or the Oregon Health Authority. Each presenter has 2 minutes to share, and in the event that doesn't feel like enough time, we encourage you to provide written testimony, which we commit to reading. To help us keep on time, we'll start a 2-minute timer for each commenter and kindly ask that commenters conclude their presentation when the timer is complete. Please know that written and verbal public comments will be reviewed and discussed following each meeting by the committee chairs and staff to determine the appropriate next steps. If you are a community partner or a sister who has a question regarding the OHP Bridge program, you can send your question to the OHP Bridge team email. The OHP Bridge team collects these questions and answers them every month at the Oregon Health Update office hours. The email address and additional information about the office hours can be found in the chat. As a final reminder, staff will not be responding to questions posed during public testimony in order to ensure that the focus remains on listening and ensuring adequate time for all commenters to participate.
Okay, can I ask my question now?
Hi, Irma. Yes, so you can ask a question as part of your public testimony. As Nora mentioned, we are not able to provide answers to the question, but we can take it back and consider it for future topics at future meetings.
Okay, my first question is, are these material are available in Spanish? Second question, how can we direct people who has private insurance and wants to be part of bridge insurance? How can we, is there an explanation in Spanish that we can guide people to do so, to see if they qualify for the other insurance? My third question will be, what's the point to have the public in these meetings if our questions are not going to be answered? That's my third question. Thank you.
Thank you, Irma.
You're welcome.
Do we have anyone else that would like to offer public testimony today? Okay. We will end this. And back to you, Nora.
Okay. Thank you to everyone who provided public testimony. We truly appreciate you taking the time to share your thoughts on OHP Bridge. Before we close out today's meeting, we have a few reminders for everyone. First, if you would like to sign up for public testimony at next month's OBAC meeting, or if you are a community partner or a sister with a question about OHP Bridge, please reach out to the email on the screen. Second, we look forward to seeing you all at next month's OBAC meeting, which will be on January 11th from 1 to 3 p.m. And finally, you can find out more about the OBAC, including its meeting times and meeting links at the OBAC website using the link shown on the screen. Thank you all for attending this month's OHP Bridge Advisory Committee meeting, and we look forward to seeing you all in January.
Great job, Nora.
Thank you, everyone. And I want to reiterate that I've dropped the email in the chat, as well as the way to sign up for the office hours for our community partners and assisters.
Thank you.
Bye, everyone. Happy holidays.
Thanks, everyone.
Thanks, everyone.
Thank you. Thank you all.